Hello, everyone, and welcome to today's program titled, The Proof is in the Data, How Clinical Documentation Improvement Impacts Patient Safety and Quality of Care, presented by Nuance and hosted by Health Leaders Media. My name is Jeff Connick, and I'll be your host for today's webcast. Our program will be 60 minutes in length. The first portion of the program is a presentation, followed by a question and answer session. As a reminder, today's program is being recorded. Before we get started, I'd like to take a moment to review the web conference platform. First, to ensure that you can see all of the content for the event, please maximize your event window. Second, be sure to adjust your computer volume settings and or PC speakers for optimal sound quality. Third, at the bottom of your console are multiple widgets you can use during the program. To submit a question, click on the red Q&A widget. It may be already open for you on the left side of your screen. You may submit a question at any time during the presentation. However, please note that we will be saving questions until the end, where the Q&A portion will then begin. Should you experience any technical difficulties during the program and need assistance, please click the yellow help widget at the bottom of your screen, which has a question mark icon covering it for common technical issues. At this time, we are very excited to offer you this educational opportunity by Nuance. I would now like to introduce the speakers for our program today. Dr. Tony Oliva, VP and Chief Medical Officer at Nuance, and Shane Wolverton, Senior Vice President of Corporate Development at Quantros. Finally, before we get started, note that the on-demand version of this program will be available approximately 1 day after the completion of the event today and can be accessed using the same login link that you used for the live program today. Also, a copy of today's presentation is available in the Resources List widget, which is located in the lower left of your screen. With that, I would like to now pass the program over to our speakers.
Good afternoon or good morning, depending upon where you are. This is Shane Wolverton with Quantros. And what we're going to do today with respect to CDI is we're going to bend the framework a little bit around how we address CDI and begin to bring in some emerging forces that are beginning to become manifest in the marketplace. And so historically, a lot of CDI has been oriented around maximizing severity of illness. And this would be expressed in terms of a methodology that you might be using at the hospital, or it might be expressed as an improvement in your case mix index. Mark Twain here is really talking about the realities of where we find ourselves, and that is, it's what we know for sure that just ain't so that kind of captures us in our intellect and in the directions that we go. And so as we think about CDI moving forward, what Dr. Oliva and I are hoping to do is to cast a different vision as to how CDI's relevance continues to increase in the emerging marketplace, and it's no longer just for internal consumption, but there are multiple stakeholders that are becoming more interested in the relevance of what we're talking about. So historically, if we think about where we've gone with clinical documentation improvement, a lot of the conversation and the discourse has been about severity of illness and CC capture, looking at CCs and MCC to drive up the MSDRG assignment depending upon what your interests are. So we thought it might be helpful to understand that there are different terms that are used very loosely in the industry that probably would be helpful in terms of defining. So with severity of illness, what we're talking about is the biological progression of disease through the body, and that's usually manifest by the most significant secondary diagnosis. And in the context of coding and documentation, sequencing becomes very important for that. There are other terms that we need to discuss because they have an emerging relevance in clinical documentation improvement. One of these is intensity, and that relates to the age of the patient, and the relationship between severity and intensity is called monotonic. And monotonic just simply means that as age increases, so does the need for resource consumption but this is in addition to considering the severity of illness of the patient. Thirdly, there's an attribute called complexity that represents the number and type of secondary diagnoses. And that is also monotonic to intensity and severity. And the importance here is complexity is not just captured in the most significant secondary diagnosis. It's actually better reflected in collecting all of the major chronic conditions and all of the secondary complications and comorbid conditions. Historically, the conversation has been around capturing the most relevant, but what we found is that capturing information on complexity of patient adds tremendously to the precision and accuracy of your information, and yet the vast majority of people that talk about CDI don't really reflect upon the complexity. And then severity, intensity, and complexity all relate to differences in resource consumption. So we're looking at continuous outcomes like charge, cost, and length of stay. Risk is the propensity for an adverse event as manifest in the probability of a mortality, a medical or post-surgical complication of care, let's say an ARC, patient safety indicator, like deep vein thrombosis or pulmonary embolism. And risk and severity are actually different attributes of a patient's confinement at the hospital. So this goes back to 1997 from Harvard Medical School, where literally back that far, what they found was that what we look at as severity systems, 3M APRDRGs, disease staging and scale, that is now a product of IBM and very rarely used, and then METIS groups, were not adequate at explaining mortality rates across hospitals because they hit on different attributes of the patient. So when we think about clinical documentation improvement, what Tony and I have seen in our many decades of work, sometimes together, is that the encapsulation of CDI relating just to severity of illness actually does not capture the full impact of what we're trying to accomplish. And so, better stated by Michael Pine, who's widely published, what we're recognizing is this distinction that severity of illness and risk of an adverse event are not always directly correlated. And what we're going to unfold for you today is the reality that there are external stakeholders that are rolling over claims data that you have submitted to outside agencies that may not have fully captured the severity of illness and the risk of the patient for an adverse event, and therefore we need to think about CDI in a much broader context than we have historically. So if we were to do a Venn diagram, the relationship between high severity, which relates to resource demand, and high risk would look something like this, where a subset of the patients fall into both categories of high severity and high risk. The reality is that the vast majority of patients will fall into either high severity or high risk, but not necessarily both. And so the challenge becomes that, as published in the Wall Street Journal not too long ago, and certainly our experience as an organization, you will find that employers and health plans, organizations running over pharmacy scripts, are beginning to mine data that originates from your claims information, and they're looking at gaps, outcomes, treatment patterns, variability, and they're doing it in a much more refined way than they've done in the past, meaning that the work that you're doing on documentation and coding improvement becomes far more important, far more relevant, because they are beginning to make more complex business decisions based on this information. And so this is driven by a number of concerns, and part of this is that if you look at, let's say, provider and carrier oligopolies, this is from the employer perspective predominantly, or the plan sponsor, is that it's clear in the work that's being done with Fortune 100 companies that they view both ACOs or IDNs as monopolistic, that they're interested in just the best performing providers. They don't necessarily want everybody. We're at a point where there's declining trust of carriers, and that they recognize that broad access networks don't necessarily move the needle for them in terms of bending the cost curve or directing their employees or beneficiaries to better value or better quality. They also recognize that we're actually at the point in high deductible health plans and consumer-directed health plans that employees are actually becoming self-insured whether they realize it or not. So deductibles of anywhere from $1,500 to $6,000 to $7,500 effectively self-insures those employees to the point where if they were to have a catastrophic illness or a major surgery or an episode that was of longer duration, they could potentially be put in financial jeopardy. And then finally, what's happening is that the C-suite is now becoming involved because historically within HR, the aversion to risk or phone calls for plan design or not having physicians or providers in the network is really moving towards we've got to find ways to be competitive, increase shareholder value, our market capitalization, and earnings per share that is going out in terms of our stock valuation. So what we're going to do is begin to tie these concerns back to your work on clinical documentation improvement and coding, because what you're going to find is that there are forces at work that are beginning to drive decision-making in different ways than what we have seen in the industry heretofore. So the first one is that there are now a more prolific strategy of high performance or tiering networks. So 17% in the largest health plans, think of this, 33% of the plans with 1,000 to 5,000 workers now include a tiered network that is underwritten differently, meaning lower cost to the consumer than what's been offered in comparison to a PPO plan, which would be a broad access plan. They're using information like the CMS MedPAR file, state all-payer data, or their own claims experience to make these determinations. And the audience on the call, many of you are the creators of this source data through the documentation and the coding that's used to deliver the claim. Narrow networks are becoming more prolific. As a matter of fact, there's a consortium of employers right now that represents around 40 million covered lives that are beginning to look at this strategy rolling out across the first 4 million lives nationally across multiple markets. And this is a severe limitation of the plan network of about 25 to 30% of providers, both physicians and also hospitals. 9% of employers currently, but that is about to change dramatically. That's actually going to become far more prolific. Many of these use PCMHs or on-site care clinics as an augmentation to the strategy so that they're actually pulling revenue out of the healthcare system as they begin to utilize these narrow networks and a centers of excellence strategy. And then finally, they're availing themselves to telemedicine, and that is that health information is exchanged electronically. 27% of employers with more than 200 employees include this benefit currently. So what we're seeing is, with these concerns that we've talked about, we're now seeing strategies being deployed in order to avert that perceived risk and find a way towards what they perceive as greater value. What we've also seen is in the last 4 or 5 years that large organizations have moved to a centers of excellence strategy. And so between Lowe's, Pepsi, and Walmart, what you see is approximately 1 million covered lives that have around 160 shoppable surgeries for every 10,000 lives. And they're directing patients and underwriting the benefit to where the employees are incented to go where they're directed to go. And this includes an evaluation on quality, performance improvement efforts, ongoing claims experience, as well as patient satisfaction and the concierge experience. So they're looking at predominantly orthopedic, spine, and heart procedures. They're doing direct contracts with bundles, and they're using claims-based source data to make these decisions, both public available data like CMS, Medicare, MedPAR, and then data that's being submitted from these institutions, which is purported to deliver higher quality or value than what these organizations might be able to get in their individual market areas within network. So with Lowe's, Pepsi, and Walmart, what you see is 1 million covered lives distributed across the nation with some high levels of concentration, but they've decided that through this claims-based information that they're going to begin to make decisions to direct them towards greater value. And the challenge here is recognizing that a lot of our CDI discussion and topics of conversation and engagement has really been around CMI or internal assessments. But what I want, Tony and I want you to understand is that we're now looking at stakeholders in addition to these that are now expanding using all of this source data that's based on documentation and coding. So there are independent centers of excellence that represent another 1 million covered lives that already have contracts with a network of about 40 providers nationally, predominantly in cardiothoracic surgery, spine, and orthopedic surgery, and they are working with Fortune 50 companies, third-party administrators, and other plan sponsors to direct care towards where they perceive to be getting better quality or more reliable quality or lower cost. In addition to that type of strategy, a narrow network is an entirely different approach to selecting hospitals and physicians. So when we talk about clinical documentation improvement, what we're also talking about is documentation and coding in the physician office. So they're looking at top hospitals in terms of the reliability of those hospitals across risk-adjusted mortality, risk-adjusted complications of care, unanticipated readmissions potentially, risk-adjusted ARC inpatient quality indicators or risk-adjusted patient safety indicators, and they're assessing quality as a primary differentiator. Now, this is currently in about 8 or 9 markets nationally, but in the next year to 18 months, we anticipate that that number will double to where approximately 20 markets nationally will be looking at both hospital and physician quality as a primary differentiator. For those of you that are not aware, CMS has just begun releasing what's called a standard analytical file, which is now 5 months in arrears to close of the quarter based on a 93% sample of the Medicare discharges within a given time period. So most recently, the fourth quarter of 2015 was released as a research file to various stakeholders to use to assess provider performance. These employers are looking at quality as a primary differentiator. So you go back down to what we were talking about earlier in terms of risk of an outcome being important and capturing all of the major chronic conditions and all of the secondary diagnoses becomes that much more vital than it ever would with respect to driving just severity of illness. They're selecting physicians based on severity-adjusted episodic information that originates in the physician office, hospital outpatient, ambulatory surgery, or in the hospital-based setting. And then they're narrowing those networks based on quality and efficiency and points of access that these specific employers need. And what you'll find is that they're in first-tier markets nationally. So you can see Chicago, St. Louis, Atlanta, Orlando, Miami, San Antonio, Dallas, Houston, Albuquerque, Phoenix, San Francisco, up in the Northeast. This will double over the next 2 years, and with now the access to both hospital and physician level discharge information, from CMS being much less latent than it has been in the past, and their own claims-based information, either from them, from their own claims experience or from the carrier, what you're finding is that these employers are now rolling over a tremendous amount of coded information, far more than I've seen in my 20-plus years in medical analytics, and making significant decisions about limiting networks in these market areas or diverting patients out of network based on plan design. So these are examples for you to look at, and these examples here relates to composite quality scoring as it relates to using statistical algorithms to capture the reliability of the hospitals delivering care within a clinical category. So what you'll find, for example, in this table is that a hospital that's rated with a check plus plus falls in the top 10% of all hospitals nationally, risk adjusted for all of their outcomes, and measuring the volume of patients at risk, the standard deviation, what's called the failure rate, and then delivering information that allows us to understand how reliable those outcomes are. The documentation and coding of the claims that we're running over is vitally important to properly assessing these providers, and this information is being reviewed on an ongoing basis by these employers, and anything here that you see in a check minus or a check double minus simply indicates lagging indicators or lagging outcomes that are happening more frequently than you would expect given the risk of the patients. And so this information is being used across the 2 million or so covered lives that we talked about, and is providing significant challenges to providers in order to keep up and continue to be current. The next slide is actually going to look at risk-adjusted complications of care. And what we're trying to move the needle on here is this expected rate of adverse events. And so what you see in the expected rate column is a direct relationship between the propensity of the patients to have an adverse event and the documentation and coding that we see. And so what you see is you have an expected rate in column 5, you have an observed rate, which is actually just collecting the types of complications, and then you have an index. So for example, at Florida Hospital, what you see is a risk-adjusted index of 0.34. When you calculate statistical significance on that, you would find that the index is statistically significant at a confidence level of 95%, placing them in the top 10% of all hospitals nationally for reliability and joint replacement. So when we talk about CDI programs, what we're actually talking about here is recognizing that we are now entering into an entirely different discussion about employers in the Orlando area that are actually looking at this type of information as part of their strategy for narrow networks and COEs. The same thing can be applied in terms of severity, intensity, and complexity, looking at clinically adjusted length of stay. This is for Pittsburgh, and you can see that we've included Cleveland Clinic here, for example. But what you're able to do is provide a clinically adjusted length of stay value that it's not geometric mean length of stay, that is more sensitive to improvements in clinical documentation improvement. So because you're not just looking at the most significant secondary, you're actually capturing all of the secondaries. Same thing with risk. You're collecting and looking at all of the secondary diagnoses. So CC capture in most significant CC is not going to move the needle if your analytics are not sensitive to the collection of all the information at the patient level. You may be missing opportunities to understand, in this case, any hospital that's in red is statistically higher in their clinically adjusted length of stay for CABG patients, and the blue line is the 50th percentile nationally, and the red dotted line is the best quartile nationally. So any hospital in blue here is statistically lower than the black line at a competence level and might be more attractive to employers or external stakeholders, especially in a market like that that's being hotly contested. And then finally, as an example, we're now looking at an episode of care that relates to asthma. And we're looking at asthma without complication and comorbidity within a severity level of 1. And you can see that the question that we might ask is, with Dr. Lutz, that as a statistically higher office charge, or the physician at the bottom that has a statistically higher bundle charge, were there actually complications and comorbid conditions? They just weren't documented and coded. And so this information gets into the hands of employers or plan sponsors, and they begin to analyze this and assess whether they want these providers to be included in their network ultimately, or it might be something as benign as they suppress them from the directory so that when a patient is looking them up, they may not see this physician, or there are a host of transparency companies out there that would take this type of content and present it along with other logic to their employer sponsors. And so as we kind of transition to kind of the next part of what we're going to talk about today is a couple things. Is first, be aware that external stakeholders are actually using organizations that have historically been aligned towards providers over the last 20 years, and delivering profiling has been used to drive performance improvement. That the need for an effective, compelling documentation and coding improvement program has never been more vital, because there are forces in movement right now that might radically alter market share, and certainly in what we'll call larger MSAs, but even in secondary MSAs, you will find that to be as well. If you're not familiar with these various outlets of your data, I implore you to know what your data looks like from these various organizations, and if it does not look favorable, you've got to dig in and understand why you might not be showing well, because it may be indicative of the fact that you're not documenting and coding sufficiently to drive the propensity for severity, intensity, complexity, or risk of an adverse outcome. There's been a lot of talk about value-based purchasing and a lot of activity on meaningful use and on CMS value-based purchasing. I can tell you, in my experience, that quality is now a primary differentiator, and there's a lot of momentum with commercial payers, health plans, and employers to now look at and assess providers based on quality, and then discarding the balance of the network if quality parameters are not met, which again goes back to the pressure of collecting all of the information and all of the diagnoses. And then finally, quality performance in underwriting risk is now becoming a topic of conversation. And this is in the context of medical malpractice, where now these insurance carriers are willing to look at outcomes performance of physicians and hospitals and recalibrate or peg the perceived risk of that entity for medical malpractice lawsuit. And then as providers take more risk under risk-based contracting, stop-loss carriers, employers that are also using stop-loss carriers or underwriting that risk themselves are finding that their capital requirements are lessening, and some of these stop-loss carriers are willing to discount the total spend in a centers of excellence or a narrow network strategy. So your documentation and coding matters dramatically as it relates to the underwriting of some aspects of the care that's being delivered by these external stakeholders. And so with that, let me turn this over to Dr. Oliva, and he will take us down for the next 15 to 20 minutes.
Thank you, Shane, and I love listening to that because I learn something new every time I hear you talk about this. And one of the things that, or one of the realities I think that are present with us at the end of the day is that we are really in competition with everybody else. And how we perform against others absolutely matters. And I want to talk more now about whether or not we can show that if you do CDI appropriately, that you can actually move that needle. It's important to you as an entity. It's important to us as a provider to show that we can actually move that needle. So what we wanted to talk about was a couple of questions that sort of popped into our mind as we started to look at this data and understanding sort of the landscape. And the questions that popped in were, first, could we show that overall there is consistency in performance that would provide supportive evidence of capture severity that exceeds the expected performance in a random database like CareCheck? In other words, if we look at our programs and the hospitals that are part of our programs, do they consistently perform better than would be expected by a random database? And understanding now that 80% of the hospitals out there have some form of a CDI program, this is a way of asking the question, are we doing something the same, better, or worse than the others out there in this world? We found that it must be, in order to be appropriate, it needed to be repetitive and objective. It had to be free of bias. And we should be able to also show a point of change with the implementation of a program. So we chose CareChecks for a lot of reasons. One, their depth of knowledge, as you could tell from Shane's discussion in this entire arena, and mostly because their review of the ratings of hospitals is significantly granular, that we could look at hospital-to-hospital comparisons. And that was vital. Other rating organizations just do not allow you to do that. And then we chose mortality because it tends to align with the capture of all of those secondary diagnoses in severity and risk. It tends to align with less variability. So that's how we chose to go about looking at the overall performance and the question, could we move the bar? And furthermore, could you trust as an entity that we can move the bar as a provider? So when we take a look at this, the first grouping that I want you to look at is the bars at the far left of the slide. You'll see the first bar says 10%. What that is a representation that we're looking at the top 10% of providers in the CareCheck database, which would be 10% of the 4,800 providers nationally that are in that database. When we looked at our partner hospitals' performance in this database at the top 10%, what we found was that about 35% year over year, federal fiscal year 11 through 14, about 35% of our hospitals were actually in that top 10%. When we looked at top quartile performance, we found that over 65% of our hospitals consistently were in the top quartile. And then when we looked at top 50%, we found that over 95, 94, 93% of our hospitals were in the top 50%. So if you think about that, kind of think of a bell-shaped curve, that's a bell-shaped curve that's moved very far to the left. So that gave us some thought that, maybe we are doing something different, because we're definitely moving the bar. 80% of the hospitals out there have a CDI program, but do we have a bias? And that was the question that we needed to solve. And the way to solve for that was to actually look at what the hospitals looked like that came into partnership with our program. And when we look at that, we find that the overall quality rating for hospitals that implemented the program in fiscal year 12, 13, and 14, you can see that they all fell right sort of in the middle of the mean, with a range that goes from very low to very high performing organizations. In essence, what that means is that the hospitals that were coming on board looked like the normal variation in the database, and they weren't biased in one direction or another. But then it also brought the question, because we are implementing something different, can we show that there is a before and after change? Typical performance improvement, implement something, measure before and after, to add some more validity to the performance that we were seeing. And we did do that as well. And when we looked at overall mortality rating, inpatient quality, and expected mortality, the blue on these diagrams is the change in rating the year before implementation, and the orange is the change in rating the year after implementation. And you can see that that transition point is quite significant. In fact, in fiscal year 2013, all hospitals in the year prior actually went down in their ratings. After implementation, they all went up significantly. So basically, those findings basically gave us some confidence that we were actually doing something to move the bar regarding CDI, meaning our focus on capturing as many diagnoses as possible and driving the appropriate principal diagnosis was different than the overall performance of hospitals in the database. So I am going to stop there and open it up so that we have some good time for questions, and turn it back over to the moderator.
Well, thank you again to our speakers for our presentation today. As Tony indicated, that does bring us to the Q&A portion of the program. So we would like to invite our audience to ask questions to our speakers, as we still have about 15 to 20 minutes to go over a few things with everybody. As a reminder, to submit a question, you'll want to click on the red Q&A widget at the bottom of your screen if it's not already opened. It may already be opened, however, and it would appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by our audience members. So, Tonya, I want to start with you real quick, and this came up with somebody, is that you had indicated that 80% of hospitals have some sort of CDI strategy. However, that still leaves roughly 20% of the marketplace that does not. What would you tell that 20%, and where would you tell them to start to kind of engage in that CDI strategy process?
Yeah, great question. I think the reality is I would say create some urgency about the reality of what's in front of you. At no other point in time has outcome performance mattered as much as it does now, and it's only going to get more significant. And at the end of the day, the only way you can be measured publicly is through that billing data. There is no other mechanism. People aren't going to come and read your record and assess it and do that kind of stuff to make some type of study. It's going to be off of that billing data. So getting that right is absolutely vital. And as we think about transitioning from a fee-for-service world to a value-based world, a strong clinically based CDI program allows you to actually traverse both those worlds in a positive way. In the fee-for-service world, you're able to capture what you deserve as far as payment for the cases and the care that you're giving, and at the same time, you're optimizing your ability to describe your patient's risk, severity, overall potential for future outcomes better. So I would say better late than never, but don't wait any longer. And I would say probably the best thing is to have someone come in that does this for a living and actually look at what you're doing and help give you a jump start on making this happen as quickly as possible.
Got it. And Shane, do you have anything that you'd like to add to that?
I think that everything that Tony said is highly relevant. I think the takeaway is that there ought to be a sense of urgency. I've heard it said for many, many years that healthcare is a local issue, is purchased locally, and I don't know that there have ever been market forces in play that are moving towards healthcare being purchased regionally or nationally based on this relationship of value. And so clinical documentation improvement is really the fulcrum of a lot of work that needs to be done. The other thing I would add is that when you think about all the effort that is being expended on performance improvement, so reducing length of stay or avoidable days, this whole issue of readmissions, looking at physician credentialing and reappointment, OPPE and FPPE, much of the source data that's driving this is coded information off documented diagnosis and procedures or notes. And so there is a lot of time and effort that we spend chasing a false positive or a false negative that could have been done differently had our documentation and coding been more thorough.
Excellent. Shane, one of our audience members asked, what are the specific benefits of CDI efforts in the behavioral health psychiatric setting in terms of maybe reimbursements and quality? If you can maybe speak to that.
That is an excellent question. I was at a major employer, and when I say a major employer, a Fortune 50 company this week, and one of their biggest challenges is behavioral health and psych. And so if you think about clinical documentation improvement and most of the care that's being delivered, let's say from an external stakeholder's perspective, is in the ambulatory setting. So it would be in a clinic, a physician office. You may have some inpatient settings, but what I find in working with employers' information is you would be surprised at how many of the episodes of care that are being evaluated don't include any complication or any comorbid condition, especially in substance abuse and psych episodes. And so many of these employers are thinking about value-based purchasing that is based on a mix of bundled rates or what's called upside and downside risk. So if the provider is able to manage more effectively, then they share in the savings that the employer enjoys. If the provider, let's say, spends more than what they did year over year clinically adjusted, then the provider might be on the hook. The lack of documentation across all episodes, but especially in substance and psych, means that we're underreporting the illness burden of those patients and setting the providers up for failure because the resource consumption and the quality will be associated with more complex patients than what outside stakeholders misperceive is actually going on. That is a really good question.
Dr. Oliva, anything from your end on that as well about the behavioral health psychiatric setting?
Yeah, I'd concur completely. I think the other thing is we hear a lot from time to time that, especially if you're Medicare, have a high Medicare psych population, inpatient psych, there isn't a lot of opportunity on a MSDRG basis with psych. and that's real. But I think that what Shane talked about is the real side of that, because not capturing the diagnosis just because they don't lead to new dollars is the mistake a lot of CDI programs tend to make, where the power is doing exactly what Shane did, understanding the significant comorbidities in that population, and as that data becomes more transparent out in the real world, and I say that basically online and available to everybody, that is going to begin to matter significantly. So be careful not to just be focusing on a lot of what CDI was known for, which was driving CMI, but think about what we've talked about today, that deeper part of understanding that it has to be comprehensive no matter who the patients are, and whether there is a financial impact that's on the sort of macro side of that discussion.
Great. Shane, I'm going to take this back to you. Somebody in our audience was wondering, statistically, has there been a correlation of decreased quality and efficiency of care provided at academic or teaching hospitals versus non-teaching hospitals? What have you seen there?
Wow, that's another good question. I would say that from our perspective as an analytics company, what we've actually seen is this monotonic relationship that I referenced before. So if we just focus on severity of illness, in many instances, what you find with academic medical centers is that they're treating older, more comorbid patients sometimes within the same severity class, meaning that the number and types of secondary diagnoses are more prolific. And so in many approaches to assess quality and cost performance, you don't pick up any of that additional information that fully reflects an academic medical center's performance. And so what we've actually shown is that many organizations that are academically oriented, so they can be teaching tertiaries, academic medical centers, AAMC, COF, actually show up very favorably in many clinical areas because of kind of a more prolific kind of consumption of their coded information, so that they actually show up favorably as frequently as, let's say, a community hospital that may treat different patients. What we also find, so if you think about the quality side, what we're saying is that in many instances, the quality of an academic institution and community hospitals can be directly compared. And in those instances where teaching or academic hospitals are treating a more complex patient, there's not as much bias in that assessment. On the cost side, there are challenges that are relevant because of the teaching program and the additional costs associated with that. But I would say that it provides an opportunity for academic medical centers to be assessed more precisely than the traditional methods have been in areas where they might treat a more complex or a patient that is at greater risk. Now, on the other side of that question is there are certain areas that academic medical centers also need to look at with clarity where they may not be let's say, as consistent in their quality as a community hospital, and it can range by by academic medical center, but there would be nothing that would be punitive about that. I will tell you that many employers that we have been in conversations with and are very interested in and are committed to the academic medical centers being a part of their strategy moving forward, really for two reasons. A, for their investment back into healthcare, and B, because they know that there are instances when those academic medical centers are a vital component of the network. That is another really good question.
And Dr. Oliva, do you have anything to add to what Shane shared with us?
I think what I would add is just what we tend to see as we look at academic medical centers, and what seems to happen a lot is that when we go in and look at an academic medical center, they do not capture the full severity level of a patient, all of the comorbidities, like you would expect that population to look like. And actually, because of that, they perform very well when a CDI program is established. So I think some of the academic nature of what they do may be part of that. I don't know, but we frequently go in and see that their patients aren't nearly as sick as what you would expect. In fact, sometimes less sick than a community hospital population, and we know that that's probably not real. So helping them understand that connection, helping them understand this world does go a long ways.
So next question from our audience, Dr. Oliva, I'm going to start with you, and that is, how do you bridge the gap between quality and CDI?
Oh, okay. So I think I would start with understanding that, well, there's two aspects to quality, right? We could talk about quality reporting like we've been talking about here, and or the actual impact of improving quality in an organization. And Shane sort of alluded to it. When you think about using quality data to drive performance, especially using clinical outcome data like mortality, risk-adjusted mortality, length of stay, complication, all of those, that variable of not capturing all of the codable elements impacts the baseline of what you're actually looking at clinically. So if you're trying to move the needle on performance observed over expected mortality in your AMI population, you better start with making sure that you're capturing the true severity of your AMI population before you even start comparing yourself to other people. Which is why we see such a tremendous change in severity-adjusted mortality, for example, after the implementation of a program. In my mind, that was sort of an aha moment as a CMO at the hospital level. It was, I needed to get rid of this variability in the capture of severity of patients before I could honestly use this data to talk to physicians and or departments about how they were actually doing in the performance of care. So I think that's one linkage. I think the second linkage is, the better the record is at telling us what's actually going on with the patient, and the fact that the records are now connected in the electronic world from one to the other, the better we define that patient, the better it is the communication to all the caregivers that care for that patient. So having a CDI program that makes sure they capture all the comorbidities, that specificity is there so that the next person that sees that patient understands what was going on with that patient down to the specificity level possible in the ICD-10 world, avoids me from having to go and read the chart to find it out and just seeing, for example, diabetes there. So I think those are the way these two worlds start to come together. And then you add all the outcome side on this because of capture of expected or severity and or risk. You just get a double whammy.
Shane, anything to add there? We do have a couple of questions, so I just want to make sure that we're getting everybody involved.
Yeah, the other thing, given the bandwidth in quality in the medical staff offices, so you look at the functions of those two areas of the hospital, coding and documentation in a CDI program that allows us to go out with confidence with the information, allows us to eliminate a lot of noise that we may be dealing with now. With respect to credentialing reappointment, it's also really important to eliminate the noise around the signal if we're having statistically meaningful variance, so that we're not triggering FPPE inappropriately. And then on the quality side, making sure that we're being efficient with our resources and being focused with our time and efforts. Those would be the two things I would add.
Perfect. It looks like we have time for one, possibly two more questions. And so, Dr. Oliva, let's go with you on this one. Has there been a successful children's hospital that has implemented a clinically integrated network that has proven clinical measurement outcomes, or is the CIN more geared to adult population for value-based reimbursements?
That's a great question because as you look at the world, most of the data we get comes from publicly available data to make determinations, right? And there's not a big Medicare population at the Children's Hospital to get that data. That being said, we have specifically begun to look at Children's Hospital. We have two partners now because at the end of the day, they typically are paid for the most part based on severity. So, and they share data significantly between each other to help understand and evolve the care that they're providing. So they initially reached out to us to talk about what we could do to assist them in the CDI world, understanding that it's different than the adult world, and even you sort of have to relook at everything that you look at from the standpoint of clinical variables because of age and other issues associated with them. But we have found significant opportunity, and they have achieved significant improvement with a CDI program. As far as payment, that really comes down to what the contracts are. A lot of this is Medicaid, which is sometimes APR, DRG reimbursed. So there are implications that may be more hospital specific as they relate to payment.
Great. Shane, anything you wanted to add there real fast?
Yes. We are working with one of the largest children's hospitals in the United States, and one of the reasons that we were brought in was because of our ability to differentiate the age of the patients as it relates to driving differences in severity, intensity, complexity, and also risk, and engagement in the kind of the children's hospital world, where they're used to NACRI and FIS reports and are reimbursed usually according to an APR-DRG taxonomy. The concern has been that many of these institutions may be negotiated out of networks, or other general short-term acute care hospitals may build up a pediatric service line to compete because they can feel they can do it more cost effectively. What we found is that there's been tremendous underdocumentation in pediatric hospitals because the financial incentives and the physician relationship with administration and others has not been favorable to kind of push that over the hump. We do see some movement, but I've seen very slow movement and socialization of those concepts.
Great, and I do just want to squeeze one last quick question in there, and again, just a very brief answer from each of you, and that is, it's a two-parter. So how do you engage coding to go to all the secondary diagnoses that are documented to reflect the complete clinical picture? And with that, are there resources available to determine what secondary diagnoses impact risk adjustment for complications and mortality? So, Dr. Oliva, we'll start with you. Shane, jump in, and just a quick minute answer maybe from each of you.
So I think the first one is that we engage by making sure that we elevate the level of communication between those two groups, the CDI group and the coding group. And we monitor and measure the fact that they do capture or not capturing, especially when clarifications are being written and being done. So there's a cultural issue around coding, truly, at every organization. It's very different. Conservatism, liberalism is present in the coding world as well. So I think you have to look at your culture, make sure that your coders understand why it's important to capture all of those secondary diagnoses, and show them with good data why that makes a difference, because I don't think a lot of times they understand that. And then as far as which are most important, I guess I would argue that all of them are important if they're clinically relevant to the care of the patient at the time. So I don't know that, clearly CCs and MCCs carry a lot of weight from an MSDRG standpoint, but I would not stop there. I think Shane would argue that the better representation of all those clinical diagnoses, the better you're going to see as far as allowing you to compare appropriately one to the other.
I would just add this
as well.
So two things. There is a way to get to very granular information around how to more accurately reflect the propensity of the patient to consume resources and to be at risk for an adverse event. The second thing is I would be an advocate of engaging the medical staff deeply in understanding why this information is important for two reasons. One is despite the availability of electronic medical record information to providers, external stakeholders will rarely, if ever, get access to that biometric or other types of more specific clinical data. So all they will have for the foreseeable future is coded information. And that physicians, what we have found is when they're engaged properly and they understand why we're doing this, are actually very eager to be involved and participate when they recognize that it's not just for financial gain, but it's actually a more precise reflection of the propensity of the patient to consume resources or have an adverse outcome. And then finally, the reason that we've come together with Nuance is to bring resources to recast CDI as to no longer just being confined to a conversation around CMI, but to actually talk about the broader discussion that really we need to tee up, and that is, how do we more precisely reflect the value that's being delivered in our hospitals, and then B, if we require remediation due to performance improvement, how can we do that more accurately and in a more timely, more efficacious manner? So there are absolutely resources that are available to investigate those things and then to implement some type of program that allows providers to improve in the future.
Wonderful. Well, that is all the time that we have for questions today. In closing, we want you to know that your feedback is very important to us. At the conclusion of the program, a link for the program evaluation will appear in the slide window. It can also be found in the program evaluation widget at the bottom of your screen. We would greatly appreciate your thoughts on our program today. I would like to thank our speakers again for joining us today and sharing their knowledge on this topic. And to our listeners, thank you for putting aside so much valuable time to watch our program. We hope you found it very informative. We look forward to providing you with other helpful programs in the future. Ladies and gentlemen, this concludes our program today. Thank you again for joining us, and have a wonderful afternoon.